Welcome to the first episode of our podcast series, Rare. In this episode, myself and Mariangels will be chatting to Professor Bill Newman around what it means to be rare and the 100,000 Genomes Project. I'm Nichola Garde, and my work in broadcasting at the BBC gave me a real passion for the telling of stories. I think being able to connect through something which we all have in common creates a conversation where we can invite everyone to join in, and perhaps then we don't feel so rare after all.
I am Mariangels Ferrer, and I have also a real passion for stories, hearing them and sharing them in ways that makes us all feel better about ourselves. Besides having an accent from Catalonia, I consider my job to be a detective of preferred stories. Hopefully, this becomes clear as we all listen many different stories.
So welcome to Professor Bill Newman, Director of the Greater Manchester Genomic Medicine Centre for the 100,000 Genomes Project.
Yes, it's a bit of a mouthful, but that's what I am.
Oh,
yes.
Good. So We're really excited to have you here today. And obviously this is our first episode of our brand new series. So how did you get involved? Tell us about...
The project first came as an idea around the Olympics back in 2012. I wasn't involved in that stage, but there were discussions amongst politicians and scientists about what could we do in science to mark the Olympics in that time. As you know, the Olympics has sort of cultural events and a number of events just as well as the sport all linked to it. And one of the ideas that came to light partly because of David Cameron's experience, who was the Prime Minister at the time. Yeah. His son had a very severe form of epilepsy, and genetic tests had been undertaken in his son and have found the cause of a very rare genetic condition. And so David Cameron and his wife became aware of the power of genetics and how it could diagnose these very rare conditions. And so through that interest, to start speaking to other health professionals and scientists and said, is this something that could be made available for more people? Are there people out there that aren't accessing this type of testing? And so it became very clear that there was a significant unmet need. Right. And there's an organisation that called Rare Diseases UK that did a piece of work that asked about 600 families around the country what their experience of having a rare disease was. And a lot of them came back and said, it took 5, 6, 7 years for us to get a diagnosis. Yeah. We'd gone to doctor after doctor and no one knew, and we didn't get to the right place, and we never had a name for our condition.
The people that I've met in my experience, that is the most frustrating thing. It's quite amazing actually how you hook to just wanting that diagnosis. Yeah. And it's really important, particularly for parents of children, just to get that diagnosis, and they can, and once they've got that, they can then start to accept or start to make a plan. It's really interesting.
Yes, I think it's really powerful, and it's important to appreciate that, because even simple things like filling out forms to access support and help, if you fill out a form and say, my child or I have this condition, it's got a particular name, people give that more weight. If you fill out a form and say, I've got this problem and that problem, and list a whole load of problems, no one really quite understands what that means. So when I think of a gene, and when I'm talking about a gene to patients, I sometimes use the analogy of thinking about a string of beads, and the gene is made up of each of the beads. In the past, when we did that genetic testing, we'd look at each of those beads in turn and look at the genetic sequence within those beads. What genome sequencing allows us to do is to look at the string, the bits in between the beads.
Right.
And that string can sometimes cause a problem with the beads, that they don't work properly.
Which makes sense, like if there's a knot in them or something, or if there's like a frame. Yeah, that makes sense.
So that's exactly what it's like. And we didn't really have a way of doing that before, and it was all considered very expensive and just a bit too complicated.
Can I ask something about this is happening in Manchester, I suppose? And
yes.
is it Manchester having a big influence on that?
Yeah, so that's a good question. So this was set up as an English-based project through NHS England, and they set up a company linked to them called Genomics England. Manchester was set up as a centre, one of the 13, and we delivered the project across the Greater Manchester area, so about 3.5 million people. And a lot of our work was going out to doctors and other health professionals saying, this type of testing is now available. Do you have patients that you've seen where you think this type of genetic information might give them the answer?
And how did Manchester respond to that? Kind of what was the response when you were out there?
Yeah, so we started off, different centres around the country did things in different ways. So we started off in genetic medicine, focused within the colleagues that I've worked with a long time, who've got a lot of expertise in looking after patients with rare diseases, who had often done a number of genetic tests on their patients but hadn't come up with the answer for some of them.
Can I check, why would that have been important to go first to the people you kind of knew?
Yes, I think it was partly because you knew that they had seen a lot of patients that had rare diseases where a diagnosis hadn't been made.
Okay, so it's almost like the questions were there already, and
yes,
the
exactly.
need was there.
Yeah, the need, we knew that there was a need there, and we knew that they would be very enthusiastic, very engaged, and a number of those doctors in that genetics team have been looking after families for 20 or 30 years without an answer, and so knew the importance of getting an answer.
And what was the response? Because I know myself, when I'm in hospital for something else, often because I think I have a rare disease, we'll discuss that later, I think I do. I don't describe it as that, but I think I do. Often, or occasionally somebody will say, and whilst you're here, would you mind being part of this study? And sometimes that's great. I'm aware that I'm going to become part of a data which could help others. But sometimes it's an extra thing. So what was the response from patients?
Whenever you set up a research project or anything that's a change in medicine and probably in lots of other areas, things take a little while just to bed in till people get to understand how things work. And so certainly we found that there was frustrations at the beginning that we couldn't quite get it going. But the patient support groups and the patients that came to our clinics were generally very enthusiastic about participating, wanting to know more about it.
And I guess, did you have to consider the kind of psychology and the social sciences around offering this kind of to patients? Was there a sense of that there could be some false hope, or there could be some, unanswered questions which could then lead them into another area, which that support?
I think that false hope is a really important issue and something that we still struggle with. One, at this stage, a number of years down the line, when the results are coming out, we're getting an answer, finding the specific genetic change that's the cause of the health problem for people with rare diseases in about 1 in 4 people, which is fantastic. It's completely transformative for them and their families, which is wonderful, but the flip side of that is 3 in 4 people that don't have an answer.
I think it's so interesting. Across what you've been telling us, there is this theme about naming things. So the importance of having a name, changing the name of the test, or how having a name like the disease, the rare disease has a name that makes a difference for these mothers, for these families, but also for you. It seems like in the quest of discovering and researching, finding names for things or your names makes a difference. Is this something?
Yeah, I think it is. There was a stage probably about 15 to 20 years ago where there were some conditions that were given names that were quite helpful in helping people remember them. So they were named after certain letters and they were put together in a little grouping or things like that. But some people actually turned around and said, actually, we don't like that name. We find that a little bit derogatory, or we find that a bit uncomfortable.
That's really interesting, isn't it? In terms of what how important that is of that association.
Yeah, and so there have been, I can't think of an example recently where that's happened, but certainly a number of years ago, there were a few conditions where the name had to change because patients said, actually, that's not helpful for us. That sort of, labels us in quite a negative way. And actually, a lot of the very rare genetic conditions traditionally have been named after the doctors that very first described the condition.
Oh, that's it. I might be wrong here, but sometimes they're named after the patient, the very first patient.
Yes, absolutely. So that's right.
That's interesting. I know Mariangels would find that interesting.
Yeah. So there's no set, sort of way in which a rare genetic condition is named. It just seems to be a slightly organic thing. So there's not a formal name process. No, that's right. And you don't follow a list or whatever each year.
No, it's interesting. I imagine I kind of have this image of you being in the room with this family you just described a minute ago, being able to tell them, well, there is a name for what you're going through, all the things that make sense. And it must be, I don't know how it must be for you personally or for all the colleagues that you have that they do similar clinics in sitting with families and being able to share that.
It's a wonderful thing. We're very lucky in genetics in the way that our services have developed over the years, in that we often have the opportunity to build up relationships over a period of time that we wouldn't necessarily always just see a family or an individual once. You would see them multiple times. You would see themselves and their family members grow up, and you would understand more about their health issues, their health needs. People, even with exactly the same condition, can have very different concerns or questions or things that are important to them about it.
And would you say this connected to social status or gender, or do you kind of, over the years, you start to notice that it's not the same a mother than a father? All these things might be,
Yes.
I don't know, maybe you've not thought of that, I'm not sure, but when you sit in front of them, probably that will have an impact.
Yeah, that's a very good point. I'm sure there is no doubt that people have a whole range of different questions they come to the clinic with. I mean, just immediately thinking of the question that's often uppermost in an individual's mind, especially in an adult, is what will this mean for my children?
Yeah.
That's very, very powerful. That's a big driver for why people come to our clinics.
Do you find that? Because I know for me, through my teenage years, I didn't think about my genetic condition at all. In fact, that's the last thing I wanted to do.
Yeah.
So I didn't want to think about it. I didn't have any thoughts about how this would affect me having children or the future. And then it was only really when I found a partner and started to think about a family that I then came back to genetics. So it's almost like I was there at the very beginning, then there's a big gap, and then I came back. Do you find many young people that come to you kind of in their teenage years, or...?
Not so many. I mean, they do.
Of course.
They're brought along by their parents often. But they often then, it's difficult to know sometimes, they take things in and then, make a sort of assessment of what that knowledge and that information is. The majority aren't very chatty in clinic.
Yeah.
They will listen and hear, and then they'll go away. And then when they come back in years to come, when they're thinking about having a family, most of them have absorbed a lot of the information. They know, they understand, but they just don't want to have that dialogue. Either they haven't sort of developed in terms of their skills in having that type of conversation, or they don't want to have it in front of their parents, especially when it might relate to quite sensitive matters or sexual matters. Having that conversation in front of parents is really quite uncomfortable for a teenager. I mean, it's tough. And we often find that engaging very young children with their parents is, before even they move into teenage years, it's quite a good time, because then they're actually far more open and relaxed about things.
And I think that's quite nice to engage young. We talked, didn't we, the other day, we actually nearly called this podcast tales from the 6th floor, and then we realised that there'll be other people that are visiting us that are not from the 6th floor. It was the feeling that I got, particularly as a patient, of pressing that number 6 button and going up to the 6th floor and going into your department and knowing that there's always news. There was going to be some kind of news, whether that, and that was really, maybe if I'd have had more interaction earlier on, I might not have felt such kind of doom almost pressing that 6th button, and I still get it a little bit now, even if I'm just coming for a meeting, it brings back those kind of memories and that kind of feeling of what it feels like to have a diagnosis or what it feels like to hear some news that is going to affect your life slightly, even short term or long term.
We are having a conversation with Professor Bill Newman. The topic today is rare opportunities and how the 100,000 Genome Project will change the healthcare.
One of the things that the 100,000 Genomes Project has sort of done has really reinforced that link with other clinical specialties. So we focus very much, and we started the project, as I said, focused in on clinical genetics. But increasingly, because of the technology, because of our understanding of genetics, we know now that doctors dealing with neurological problems, so neurologists, cancer specialists, heart specialists, paediatricians, they will all be using genetic tests. It's not appropriate for every one of those patients seen by those doctors and clinical teams to come to a genetics department. We're not able to sort of see all of the people that need a genetic input.
I find this fascinating to hear how is this impacting everybody, the sense of velocity, that the technology is changing, it's less expensive, you were saying. Your role is changing because you were doing that and now you seem to be the consultant and the support for other clinicians maybe, or the role is changing very quickly. Patients maybe, your generation is different from your children's generation.
Maybe they could go into the GP
there
eventually.
Is a different...
I think that's right. So I mean, one of the things that we have to be careful about is not trying to pretend that genetic information, genomic tests are important for everybody in every situation.
I think that is really, because I think, and I don't know if this is partly media or politics, suddenly I think everybody thinks they have to run out and this, the other things that are on the market, and kind of say like, we all need to have our genes. And I think it's definitely something that we talk about a lot is like, how do we kind of relax that a little bit? And it's not, how do you communicate that, I guess I wanted to ask.
So that's sort of interesting in that I've never had a genetic test. I've got no intention of having a genetic test. I deal with genetic tests every day of my life. It's what I think about, what I sleep, eat and drink, but I've got no intention of having one myself. One, because I wouldn't dream of having a genetic test without discussing that with my partner, my children, my sisters, because any result that I have for myself would have implications for all of them. So I think it's really important to think about that and the reason for having a genetic test, and you feel or you're supported that you can interpret the results of those that can make some difference to you. I think that's incredibly valuable. But for me, even though I'm a geneticist, if I had a whole genetic test looking at all of my genes, I still wouldn't really know what that means. And even if I found a change in a gene that is known to cause a particular health problem, there's very good evidence that in healthy people without a family history of that condition, that genetic change might not actually ever cause any health problems. And so you're living your life thinking that you've got a health problem, where actually you don't. Every one of us in the world is walking around with lots of genetic changes.
And I think it's also what we often define as a health problem, because you and I might define a health problem completely differently. And I could live with what is perceived as a health problem and not see it as a health problem at all. And actually, rarely have to see the GP or the doctor and rarely have any medical issues at all. But by definition, my condition could be a health problem.
Nick, this is almost philosophy, isn't it?
Yes.
What it is a disease and what is not.
Absolutely.
And what is rare, because we've been talking under the umbrella of rare disease. And rare disease almost sounds I don't want to put an opinion, but it sounds a particular thing. So if you have been doing research for this rare disease, and in 10 years' time, maybe they're not rare anymore, or they are.
Yes.
No, I don't know what it's.
Yes, that's a very good point, because the definition of rare is different between Europe and America.
Is it?
And
is it?
Yeah, and
Really?
so in the UK and in Europe, because the UK is still
moment.
part of Europe. Yeah.
Is it?
Yeah. Just about.
I know. If your condition affects less than 1 in 2,000 people, is considered to be rare.
Okay.
So actually, that encompasses a lot of conditions.
Mm-hmm.
And I think one of the things.
So are we more rare in Europe? Is this what?
So in the USA,
definitely.
it's 1 in 200,000. So it has to be much rarer
Wow, that's
in
right.
America.
That's a
to
big
be
gap.
classified. Big gap. Yeah. So I don't understand quite why that's happened.
Once you found what the name of your condition is, or rare disease, you then want to find a community that has that same
Absolutely.
support. But I guess the rarer we get, that smaller that community could become.
Yes.
And that might be quite difficult. I was listening to something this morning actually, and it was about a rare cancer, and she was saying there was only 4 other people in England that had, and she found that really, really difficult because she wanted to find a community or a support group, and there was just literally 4 people.
And really, psychologically, if you are isolated in any part of your life or in any relationship, this is the hardest thing to be. To be isolated is.
So I think a lot of people, that was a sense that a lot of people, before their conditions were diagnosed, did feel that sense of isolation. So there's a very important support group who does some great work called SWAN, so Syndrome Without a Name, and they provide support for people who have got health problems and no one quite knows what it is. And I think they very much feel that some of their patients and members feel that sense of, I'm just drifting, I'm lost, I don't have.
It's interesting that we feel that though, isn't it, as human beings, that we need to be part of a tribe almost still, like we need to kind of find people that are like us and go, great, we're all together now and we can support each other. And maybe not all of our lives, but maybe through certain
I mean, one of the things though that can be challenging, I think, within support groups as well, is that to some degree, some support groups have been set up by people who are more significantly affected by a particular condition. And so that can be really challenging because if you're very mildly affected or you have a very different experience of a condition, and then you go to a support group and you find that the members there are all very severely affected, that sense of, oh my goodness, that's going to be how I'm going to be affected or my child's going to be affected, can be really quite devastating because it really completely changes their perception of themselves and their own health and what their future health might be. And so being careful about making sure as much as possible that those support groups are as inclusive as possible and have the full spectrum of the condition where that's possible.
Do you think you've changed, like since the beginning of the project to now? Do you think, you found out, do you think you've changed at all?
Oh, that's a good question. Yeah, it's a bit of self-reflection.
We have to have a bit of that, don't we?
Yeah. So I was a little bit more sceptical at the beginning of the project about what it would achieve. I think it's fair to say I have been delighted with the fact that some of the results and some of the diagnoses we've made and the impact that has made. So that has been a very positive thing. I still have that frustration that we have to some degree potentially fallen into that trap of overselling the project, and there are a number of people out there who participated in the project and I think probably had a greater sense that they would get a positive outcome, they would get an answer from their genome sequence, and we've not been able to deliver that. It's not for lack of trying, it's just that the technology isn't there, we don't have the knowledge to unravel the genetic information to say, yes, that's the answer, that's the explanation. And I think that people probably felt that there was more likelihood that they would get an answer. But I appreciate that you're trying, that you're still interested, that you're still looking, and that's something that I think has been really wonderful for us in genetics, where we have some new information about a condition and we have the opportunity to go back to a family file and you get in contact with a family. The appreciation that you get from families and individuals saying, thank you for still thinking about me, for thinking about our family, for trying to work out what has been affecting us, what the cause of our condition is a great motivator. It's a wonderful thing when you get that sort of feedback. And rather than people thinking, gosh, why is it taking you so long? People are actually really very wonderful in their responses.
I mean, this question I have is maybe a fantasy question, but I wonder how different it had been for you as a doctor, as a professional, as a person, to be part of this, to be part of it from the beginning or from so long, and how do you think you see yourself being different because of that, being part of this project?
So, I've been in genetics now for nearly 25 years. And about 10 years ago, when there was the first talk about this new technology, I couldn't imagine for a second, I don't think I had the imagination to think that I would be able to order a whole genome test in my clinic for a patient and get an answer. I didn't believe that we'd be able to afford it. I didn't believe the technology would move on so quickly. I didn't believe and understand that we would be able to analyse the data and get those answers. So that's been truly fantastic. It's been a real eye-opener to me just to see the pace of change. And for people who for years and years have had no answer, to be able to deliver that, at least for some people, has been truly wonderful.
We hope you are enjoying the podcast so far. Please subscribe, rate and review. Continue to follow our conversations where we discover that rare means different things to different people.
I believe that there's an enormous amount of genetic data that's already out there and available that we're not really applying and using in clinical care. So there's loads of research, loads of interesting things that we found, but we've not been able to take that into the clinic and into hospitals. And so one project that I'm focused on at the moment, which is my main passion, I suppose, is that we've been working with the neonatal unit here in Manchester and the one in Liverpool. And so every baby that goes onto the neonatal unit gets given an antibiotic called gentamicin.
Oh yeah, I've been reading about this because it's hit the media a little bit, hasn't it?
A little bit, yes.
Yeah, I've been reading about this.
Yeah, so...
when was this shift, moving from knowing things to because this means you're starting to collaborate with these people that they do the machines, you're collaborating maybe with parents, with nurses, I don't know. It's a different type of work.
Yes, it is a different type of work. So it's shifting from discovery into what we'd call implementation. And actually one of the important things for us is to convince the funders of research, both within the health service and the big funding organisations, that it's great discovering new things. It's wonderful discovering new things, but the balance isn't quite right at the moment. All the focus is on discovery, and it's not on how do we move that discovery into actually working and happening. When a baby is just born and is rushed to the special care baby unit because they're ill, the question is, do you at that point say to the mum, oh, would you like your baby to have a genetic test? Do you go through a consent form? And we said, we don't think that's right. We're not being paternalistic, but we don't think that people necessarily are in a state of mind to be thinking about all the implications of having a genetic test. And when people hear genetics, they think, oh, well, they might find out this, or they might find out that. It's very difficult to then go through in that very pressured setting, maybe in the middle of the night with lots going on, lots of machines, you've just had an anaesthetic, you're recovering from your cesarean section or whatever's been happening, and all you've got is that worry about your child and wanting them to be okay.
How do we call things makes an impact, and the language makes an impact, and educating people.
Definitely, and I think it also makes an impact in terms of that kind of social, like the medical model almost, versus the social model of terms and names. Like even for me, I still struggle with saying rare disease. I do, and every time somebody says it, I kind of go, oh, disease, I'm not sure how I feel about, and kind of, because that language to me feels like it's something that needs to be...
What do you associate rare with, if you...
It's probably changed throughout my kind of, but I associate rare with being kind of special, probably, but then also special in a way that can influence other people. So there's something about, like, it's quite cool to have something that's rare, because then you're walking around, especially if you have a rare disease that that is visible.
It's visible,
because then you're actually, just by being in people's presence, you're making it not rare. So in where I live, like my family, 3 of us have achondroplasia, so we're not rare anymore because people have seen us so much that we're not rare. People don't even notice as we walk past, and I think that's almost like, in terms of from that model, that's where I'd like rare to become. That you don't feel like you're this blue person in a room full of red people. That you actually, or even if you are, you don't have to hide that, but it's okay to be blue.
Absolutely.
I think that's how I see it, so that it becomes less rare just by being around and present.
So it's not so much about the blue person, more about the red group of people that need
and their response.
It's them that needs, it's that needs to change. It's the response of the red people rather than I don't need to change. Well, I do on some areas, but not with that area. But I think that's how I see. What about you? How do you see?
Well, I see the same. With my accent, I walk. If I don't talk, I am different when I open my mouth in an English country, and so I notice my rareness in this quite a lot. And when I am in Barcelona and speaking Catalan, nobody I need to make visible that I don't live there anymore. So it's so interesting. I know it's a different thing, but still.
No, but it's similar, isn't it? But it's identity. What about you, Bill? How do you see rare?
I've been a Liverpool fan living in Manchester for the last 30 years. So
hard.
that is rare. That's been very tough. That's how I've stood up. I keep it quiet.
Brilliant. This podcast has been made possible by our brilliant team.
Rona McLeod,
Ramona Moldovan,
Jay Roach,
Mariangels Ferrer,
Nichola Garde,
Fiona Oof,
Nick Jordan.